Hello, I'm Dr. John Kruse, and today I'm going to be talking about serotonin syndrome. Do I need to be afraid of it? So the take-home message is if you're on an antidepressant, you've probably gotten notices from the pharmacy or seen black box warnings in you read the package insert that you're at risk for serotonin syndrome, which is an excess of serotonin at the synaptic level. And it can be a potentially serious, even lethal condition. You're clearly more at risk if you are on more than one medication that's affecting serotonin. And there are lots and lots of people on serotonergic antidepressants in this country. Probably more than 10% of the US population or close to that's on an SSRI, and another 3, 4, 5% are on other antidepressants, many of which also interact with serotonin. But the bottom line is, even though this is a spectrum and there are certainly milder forms of it, serious cases of serotonin syndrome, even if you are on multiple drugs affecting the serotonin system, are quite uncommon. And the most serious ones are really quite rare. I'll get to some of the data we have. So yes, be cautious if you have sensitivity to medications. Yes, be aware of what some of the symptoms are, which I will get to. But this seldom should be a reason to avoid medications which may otherwise be appropriate. So why am I talking about this now? We've known the existence of serotonin syndrome for at least 30, 40 years, although lots of doctors outside of psychiatry are less familiar with it. Attention to it has been growing, again, thanks to black box warnings and others. And there's some speculation that even though we've only identified the existence of serotonin as a specific neurochemical in the last century, that maybe maybe ergot poisoning, when ergot's a fungus that grows particularly on rye and some other grains and caused both hallucinations and muscle spasms and syndromes that probably look like serotonin syndrome. That's been around and dedicated. There were clinics actually dedicated to this in the Middle Ages, run by monks, so more than 1,000 years ago. So probably serotonin syndrome's been with us for a while, even if we're only recognizing now. So yes, we should be aware of it. Yes, we should learn more about it. And no, I think in many cases we're overreacting. So why I'm talking about it now is that there's an antibiotic called linezolide. It's a good oral antibiotic. It's very effective against a host of gram-positive organisms that can cause pneumonia, skin conditions, bacteremia, bacteria in your blood. So it's often a good step-down antibiotic if you've needed antibiotics IV in the hospital. But it does have some monoamine oxidase inhibitor action or ability. So the warning, and it's been a black box warning since 2020, that you should not take this if you are taking an SSRI or most other antidepressants. And a black box warning doesn't mean the doctor is breaking the law. Black box warning is just a strong suggestion that there's a potential for interaction or danger with this medication. It's the most severe action the FDA can take short of actually banning or recalling a product. But it isn't ruling out that there may not be good reasons to violate the black box warning. Clearly, a variety of studies have shown when a drug has a black box warning, doctors are less willing to prescribe it, whether that's appropriately less willing or inappropriately, and it does hurt sales of those drugs. So linezolide has been on the market, probably not used nearly as widely or extensively as it could or should have, and that means probably some people have died from infections who might otherwise not have. So a Canadian group did a study recently. There have been other studies trying to sort out. I mean, there have been case reports of serotonin syndrome on people with an antidepressant and linezolide at the same time, but that doesn't show you how common or how likely it is. So the crunched the numbers in Canada. I had more than 1,000 people who were on linezolide and looked at those who were on an SSRI at the same time versus those who weren't. And one is the likelihood of serotonin syndrome. And again, this is an elderly, not just an elderly, but a sick and elderly population. So these were, I think everyone is over 65, or at least over 60, and on an antibiotic for a serious infection. The rate of serotonin syndrome was less than 0.5%. And when they crunched the numbers, actually being on an antidepressant while you were on linezolide, you actually had a lower chance of developing serotonin syndrome than not being on an antidepressant. Both groups, it was quite low, and how significant the difference is hard to detect because it was so low. But so this group and commentary by others who were not involved in the study but seeing the data were saying we probably should remove that black box warning from linezolide. It does not appear that this is a clinically common or serious, likely to be serious interaction. Yes, doctors should still be aware of it, but again, maybe we're holding back a life-saving antibiotic in cases where it would be helpful. So jumping more to serotonin syndrome, what it is. So start with the basics of serotonin. It's one of our indolamine neurotransmitters. It's made from the amino acid tryptophan. Tryptophan dehydroxylase in 2 chemical steps modifies tryptophan to 5-hydroxytryptamine, which is serotonin's other name, 5-hydroxytryptamine, which is why it's often abbreviated 5-HT. The nerve cell bodies in the brain that contain, so we hear about serotonin and dopamine and norepinephrine all the time, yet all of these, or each of these systems, is a tiny, tiny numerically less, each of them is less than 1% of the neurons in the brain primarily use it as a neurotransmitter. So numerically, serotonin is not a big component of neurotransmission in the brain, but it's a highly important one because cells in the raphe nucleus at the base of the brain, I can't really point inside to where it is, ramify, they spread endings, modifying, modulating neurons throughout the brain. So rather than thinking of serotonin as a neurochemical that does something, thinking of it as something that modulates lots of systems, including emotion, including lots of aspects of the gastrointestinal system, the sexual response system. So that's why monkeying with serotonin can have lots of different effects throughout the body. So with serotonin, we have 14 different types of serotonin receptors, and the serotonin receptors are divided into 7 different classes, 1 through 7. Again, 14 specific. Serotonin syndrome is thought to be, again, when there's way too much serotonin in that synaptic cleft acting on serotonin 1A and 2A postsynaptic receptors. So those are the downstream ones. So how or why would you get too much serotonin in the cleft? So one possibility is if you're making way too much serotonin, that's kind of hard to do, but if you took massive overdoses of tryptophan and it was getting into your bloodstream, that could be one contributory factor. In and of itself, it's not likely, again, to boost serotonin to toxic levels. You could block the breakdown of serotonin. So usually, when the serotonin is taken back up into the cell that released it, that's, I'll get in a moment, to serotonin reuptake inhibitors. But also there are chemicals, specifically monoamine oxidase, that breaks the serotonin into 5-hydroxyindoleacetic acid and deactivates it. So we have specific antidepressants that are monoamine oxidase inhibitors and some other things like the herbal medication. St. John's wort has some MAOI, monoamine oxidase action, as does, again, some other drugs that you wouldn't think of on the surface, like linezolide, which is an antibiotic, have some MAO action. So there's certain drugs that cause the presynaptic nerve to release extra boluses of neurochemicals. So things like amphetamine, and particularly MDMA, dextromethorphan, which is in cough syrup, and it's also in the newly released fast-acting antidepressant Auvelity. All of those have some potential for contributing to serotonin syndrome because they're causing a greater release into the synaptic cleft. In the past few decades, we've also learned that blocking the serotonin 2A receptor, even though, again, some of the effects of serotonin syndrome are overactivation of the 2A system, but blocking it can also contribute to a buildup in the cleft of serotonin, and particularly our second generation antipsychotics. So the newer antipsychotics have been implicated in some cases of serotonin syndrome. But the biggest numerically and the most common way to overreduce the amount of serotonin in the cleft is through serotonin reuptake inhibitors. So again, usually serotonin is pulled out of the synaptic cleft by rebinding to the nerve cell that released it and being taken back in. So serotonin reuptake inhibitors, cocaine, MDMA all have reuptake blocking action. Also remember that we have some drugs that are serotonin and norepinephrine reuptake inhibitors. So duloxetine, which is Cymbalta, venlafaxine, which is Effexor, and some of the older tricyclic antidepressants have good serotonin reuptake action, particularly clomipramine and imipramine. So all of these could contribute or create a situation making someone prone to developing serotonin syndrome. And another potential way is for drugs that inhibit some of the liver enzymes that affect how these other drugs are metabolized. And so P450 inhibitor, so P450 are a class of enzymes in the liver that chew up and break down drugs. And probably there's been a few cases of bupropion, Wellbutrin, also Zoldaziban, implicated in SSRI, Serotonin Syndrome, which seems weird because it's primarily thought of as a dopamine and norepinephrine reuptake inhibitor with pretty weak action on serotonin. But bupropion's a pretty good inhibitor of the 2D6 version of P450, and the 2D6 is the version that breaks down several of the SSRIs. So the bupropion in combination of them could boost serotonin in the cleft. And actually, when bupropion is combined with dextromethorphan in the form of Auvelity, it's there specifically to make the dextromethorphan last longer. And again, that can boost serotonin in the cleft. One group of drugs I've left out is that some of the opioids have been implicated in serotonin syndrome. So particularly tramadol, methadone, again, dextromethorphan, all of these and some of the other opioids can have some reuptake blocking action and essentially boost serotonin action in the cleft. So what is serotonin syndrome? And some would actually strongly prefer the term serotonin toxicity. So again, a syndrome is a collection of signs that go together to create a specific toxic condition, pathology, whereas calling it serotonin toxicity emphasizes that this occurs on a spectrum. If levels are boosted somewhat, you may have milder aspects of, and there's 3 different areas that serotonin syndrome, 3 different ways it affects the body. So the first is altered mental status. It also can overactivate the autonomic nervous system, and it causes neuromuscular issues. So the altered mental status is usually anxiety, agitation, confusion. Again, at the mild end, that might actually look like the condition you're treating. So that's part of why it's important for doctors and patients to know what's going on. So a mild increase in anxiety, maybe at the very mildest end of, so about a quarter of people starting on a standard dose of an SSRI feel a little more physically agitated, a little more anxious, sometimes even confused. Again, that's probably at the mild end of serotonin toxicity, and usually either backing down on the dose or just waiting a few days, that gets better. But severe end of the spectrum, it can be full-blown paranoia and not just mild anxiety. It can be complete disorientation and extreme confusion. For the autonomic nervous system symptoms, and again, these occur on a spectrum as well, but it's being sweaty, increased heart rate, increased temperature, increased blood pressure, vomiting, diarrhea, overactivation of the gastrointestinal system. I forgot to mention when we were talking about serotonin, most of the serotonin in the body, upwards of 95%, is made in the gut by gut bacteria. So lots of activity for serotonin in the gastrointestinal system. And the third set of symptoms for serotonin syndrome is neuromuscular hyperactivity. So rigidity and spasming, myoclonus is a fancy word for it, and hyperreflexes, particularly when it gets more, can be eye movement, myoclonus of the ocular muscles controlling the eyes. And although particularly its lower limb, it's rigidity, hyperactivity, hyperreflexia, clonus in the legs, which is particularly common. And when this isn't, again, so most cases of serotonin syndrome are mild to medium. Most of them show up pretty rapidly within 24 hours of starting or adding on a new serotonergic drug, although some cases can take a few days later, at least in one study. Usually, if it's mild, again, stopping the drug is enough to make it get better. But if things are ramped up to a high enough level, seizures can occur, breakdown of muscle tissue, which is rhabdomyolysis, which can cause renal failure, respiratory distress, internal bleeding when disseminated intravascular coagulopathy, because serotonin's also part of what's involved with platelets sticking together and forming clots. So again, then there certainly have been deaths associated with serotonin syndrome. So all of these together are a clinical condition. You can do lab tests, lab tests confirms that your blood pressure is elevated. That is a form of lab test. It can look for muscle breakdown. But we do not have any specific lab tests that confirms or disconfirms serotonin syndrome. There have been some approaches, several different approaches. The most recent one that's most favored by experts is called the Hunter Serotonin Toxic Criteria, where in conjunction with the introduction of a new serotonin agent to the person's body, if you have one of certain other features, then that's considered qualifying you for serotonin syndrome. So certain forms of clonus in combination with that serotonin syndrome, or sweatiness and other forms of clonus together, or high temperature and other forms of muscle. So there are one particular condition this can be confused with, particularly in the psychiatric population, is NMS, or neuroleptic malignant syndrome. Neuroleptic malignant syndrome is due to another neurotransmitter system, so that's due to dopamine blockade. It's, I would say, more frequently a severe and potentially lethal condition. And there's overlap, particularly some of the confusion, some of the can be agitation early on. Fever is also a hallmark of NMS. But in contrast to the serotonin syndrome, bowel activity is usually shut down or slowed down. So instead of vomiting, diarrhea, and hyperactive bowel sounds, bowel is quiet in NMS. And even though there might be rigidity, it's hypoactive muscles in NMS. So they're sort of flaccid and not hyperreflexive, hyperactive. And NMS often takes several days to develop after a change in medication, again, where most of the time serotonin syndrome happens quickly. So one of the places that I've often seen pharmacists warning patients is, oh, if you're adding trazodone for sleep in a low dose onto your SSI, you shouldn't do that. That's going to cause serotonin syndrome. Or if you're adding buspirone to an SSRI for anxiety, you shouldn't do it because it's going to cause serotonin syndrome. The fact of the matter is the vast majority of people on trazodone, since it's been around for 40 plus years, are taking trazodone in conjunction with another antidepressant. The vast majority of trazodone use is not as an antidepressant itself. That's what it's FDA approved for. It's most commonly used to aid in sleep, usually at doses below a full antidepressant dose. But the vast majority of the time, trazodone is prescribed and prescribed safely with an SSRI or with another medication. Similarly, buspirone, FDA-approved use is for anxiety, but we also know that it is an effective agent for boosting the efficacy of antidepressants. So my estimations from looking at the figures and what I've seen clinically, at least half the time buspirone is prescribed, it's being prescribed on someone who's already on another agent. And the vast majority of the time, that is not causing a problem or serotonin syndrome. So to put some of this in perspective, again, about 10% of Americans are on an SSRI. In the most recent year I could find data, 2021, the Poison Control Centers identified 90 cases of people dying from serotonin reuptake inhibitors. Maybe another 80 cases of individuals on other antidepressants, which also can affect serotonin. So maybe a total of 170. The vast majority of these, more than 90% from what I could look at, were intentional overdoses of massive amounts, taking a month or more's worth of medication. So in this regard, we know the SSRIs are at least an order, maybe 2 orders of magnitude safer than the old tricyclics, where often 10 days to a month of medication, a month of most tricyclic medications would be lethal. Clearly, most people who take even a month's worth of fluoxetine, Prozac, rocetine, citalopram survive, and again, they may have serotonin syndrome. So to put that in perspective, 170 Americans died from SSRIs in 2021. Again, most of those intentional overdose suicide attempts that were completed suicides. Put that in perspective, at least 202 people died from deer killing them in this country in 2020. And it's not that deer are running around with AK-47s, or I don't even know the machine gun terminology. It's through car accidents. And most people aren't afraid to get into a car because, oh my God, a deer is going to kill me. If you're in Pennsylvania, if there's certain times of the season where you're traveling on highways where you're in deer country, you may be more vigilant. That's why we have some roadway signs. So it's not ignore the risk completely. That is why we put up some of these signs. But it's not that you should be terrified that this is likely to happen. So I think some of the excessive warnings are crying wolf rather than putting it more in perspective that this is likely to be less harmless to us than a deer is. So I will be getting back to some more ADD topics in May. We're coming up with a schedule soon, and I do see that there's at least a few questions here. So the question is, and I think I addressed it while I was talking, is again, there have been hypothetically 5-hydroxytryptophan, so supplemental tryptophan, taking it to boost your serotonin. Again, it makes 2 metabolic steps by tryptophan dehydroxylase to get from tryptophan to 5-hydroxytryptophan, and then from 5-hydroxytryptophan to 5-hydroxytryptamine, which is serotonin. again, that could contribute to having more availability of a product. That could, but clearly lots of people are taking 5-hydroxytryptophan in conjunction with an SSRI. Statistically, I'm sure it increases your risk slightly, but overall the risk is still quite low. So I'm not seeing any more questions. I will be going back to Tuesdays. This was a special Monday offering because I'm out of town tomorrow and traveling. So stay healthy, stay happy. If you have topics you'd like me to talk about, or you think there's a better time for me to be talking live, you can certainly give me feedback through this channel. That's all. Bye.